Hello everyone. Today in our series of Docplexus KOL interviews, we have with us a renowned urologist, Dr. Anil Bradoo. He has an experience of more than 30 years in this field and he is the secretary of the USICON Conference 2017. He has got specialization in various fields of urology, ureteroscopy, open prostatectomy and PCNL. Thank you so much, Dr. Bradoo, for joining us today.
Thank you very much.
The first question that I like to ask you is if you can share your experience regarding the surgical advancements made in the management of kidney stone removal.
Management of kidney stone disease is actually changed rapidly over the last few years. Percutaneous nephrolithotomy, which used to be done with a 28 French size access, can now be accessed with a size as small as 9 French. That is the advance we have in the nephroscopes used for stone removal. In fact, there is another procedure called as micro PCNL, where just an 18 gauge needle is used to access the pelvic ileal system by doing a puncture, and with the help of a fiber optic camera and a laser fiber, we are able to fragment the stone completely. Barring PCNL, direct access to the pelvic ileal system from the urethra, we are able to access the entire anatomy of the kidney because of the 270-degree torque which is available, the curve which is available for the tip of the instrument to go into any calyx. And therefore, there is no invasion at all. We do not have to puncture at all. The third advantage is in extracorporeal shock wave lithotripsy, where with shock waves you are able to fragment stones. So these ESWL machines have become very compact and can be used with the focus of either fluoroscopy or even ultrasound technique to be able to shatter the stone completely into small fragments. So all these three procedures which I have just mentioned can be used in different situations to be able to break the stone completely. One would think, how can a kidney completely packed with stones, which is almost say 6 centimeter or 5 centimeter in size, be broken with a minimal invasive technique? Yes, what has happened is that not just access and the endocamera and the light source has advanced, also the energy which you use to fragment stones quickly has also advanced. And now you have what is called as a shock pulse lithotripsy, where the ultrasound energy along with the pneumatic energy is both encompassed in a single device, and we are able to break a huge stone, 5 to 6 centimeter stone, which would normally have taken 2 hours, in less than 20 minutes. So these are the advances. Even in the huge stones, we are able to do minimal invasive procedures quite efficiently.
So how feasible is risk prediction in cases of kidney stone?
Well, risk can be easily predicted by knowing the anatomy of the kidney. So we have to assess the function and the anatomy of the kidney by doing what is called as a CT urography. So a CT scan with contrast is able to image in 3 dimensions the entire anatomy of the pelvic ileal system. So we know how to minimize access and to be sure that the access is in the right place. Mind you, most of the complications or the risks are because of the access. The rest of the technique, once you have got familiarized with, hardly produces any complications.
So, moving on to kidney donation. So, can a living kidney donation be accepted from a patient who is a stone former?
In very rare cases, when the stone is harmless, it is a very small stone lying in a peripheral calyx, and the anatomy has been judged, and the patient does not have any other risk factor for stone progression. That means he's not been a known stone former, he's not had multiple procedures in the past. Then you know that this is a silent stone or a incidental stone finding, and that you can take the risk of taking this stone for kidney donation. But by and large, if you have the history of stone disease, or you have more than one stone, or the anatomy of the pelvic ileal system is distorted, then one would not prefer to use that kidney for kidney donation.
So how do you differentiate and treat different stages of prostate cancer?
Interesting question. Prostate cancer has many stages, and in fact, a lot of treatment options are available for prostate cancer. So let's put it simply. If it's a low grade, low stage cancer, limited in size and volume, then options depending on the age of the patient and the risk factors is either surveillance or just mere observation with clinical digital rectal examination of the prostate, routine ultrasonography, and prostate specific antigen evaluation be done to check if this is progressing, then we intervene. The second option, of course, is if the grade is slightly high or the risk factors are high. When I say risk factors are high, that means if there's a family history of prostate cancer, then such a patient you wouldn't want to put on local surveillance. You advise the patient radical prostatectomy, whether it is done by an open technique, which is rarely done nowadays. What we would do is a laparoscopic radical prostatectomy or a robotic radical prostatectomy. So these are the options for early prostate cancer. If you have a locally advanced disease or a high-risk patient with prostate cancer, then the second option for curative therapy is giving external beam radiotherapy. That is also good, has good results. In certain cases, you can do brachytherapy, wherein small needles are inserted and iridium or iodine seeds are inserted into the prostate through a transurethral ultrasound guidance. So you can also do brachytherapy in certain cases which are high risk. When you have advanced prostate cancer, the first treatment of choice still recommended is hormone deprivation, because we know prostate is dependent on testosterone, and either surgical castration by doing a bilateral locketectomy or medical castration by using an LH-RH analog is the treatment of choice. And this is how we primarily decide to treat prostate cancer. Then, of course, if the patient does not respond to hormone deprivation and is failed control of the hormones, there are other treatment modalities available, but I think that's a little bit too advanced to discuss at this stage.
So what are your thoughts on mitochondrial dysfunction, and does it lead to mitochondrial spermatopathy, and what are the role of micronutrients such as coenzyme Q10 in OAT?
Well, I don't know whether there is a lot of evidence on this, but in selective cases where you're dealing with, say, for example, a count of 10 to 15 million, your motility is less than 40%, your age group is between, I would say, not more than 35 to 40, then you have a fair chance of responding to these medications. And a fair trial of up to 6 months with CoQ is recommended. So these are select patients in which you do not mind 6 months to a 1 year therapy of CoQ enzymes.
So you have been the key person of organizing this huge conference. So what is your message for the urologists who could not attend this conference?
Well, the first and foremost, we had more than 2,400 urologists registering for the conference and taking interest in following the conference from day 1 to day 4. You can see from my eyes, I'm already tired last 4 days with the content of the conference. The fact is that all the urologists have attended this conference with a lot of dedication, and the facilities available here with the national and international faculty were of very high standard, and therefore the clinical material available for discussion of presentation was enough for people to be able to stick on to the halls and the auditoriums in which these discussions were going on. So not many have really missed, but yes, as a matter of fact, I would assume about 800 urologists were not able to come. You do need urologists back home in their hospitals treating patients too. So my message to these urologists is, well, Docplexus has been kind to cover up some of the key opinion leaders and probably will get access to some of the discussions and surgeries in the live operative workshops which are conducted, and should be able to bring to you excerpts of UCCon 2017. No conference is complete without DVD which actually covers the entire conference, and I think the organizers of UCCon 2017 are also planning to do the same. So yes, access for teaching and for education will be available to all the rest of the members too. I wish all the members the best, and I hope the ones who missed 2017 will be able to make up in 2018.
Definitely, sir. And thank you for partnering with Docplexus.
Our pleasure.
And we are glad to have you on the platform.
My pleasure. Wish you a good day.
To stay updated on our latest scale videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy Docplexing!